Usually when we talk about a medical diagnosis, there's this expectation of precision. It's almost treated like engineering.
Right, like a math problem.
Exactly. Like
Yeah.
you break your arm, the x-ray shows that jagged white line of a transverse fracture, the doctor points to the film, and the path forward is just totally binary.
Yeah, the bone is broken or it isn't.
Right. We cast it or we don't. It's simple.
And, it's a really comforting paradigm because we inherently trust what we can visibly categorize. The mechanical failure of a bone just feels so solvable.
It makes sense to us.
But the moment you step into internal medicine, into the complex, interdependent plumbing of the gastrointestinal tract or systemic inflammation, that metaphorical X-ray machine just shatters.
It totally falls apart.
It does. The diagnostic landscape becomes incredibly murky.
Yeah.
Symptoms overlap. Physiological cascades kind of mimic one another.
And handing a patient a standard issue pamphlet filled with like decontextualized Latin terminology is functionally useless.
Oh, absolutely useless.
I mean, it's worse than useless. It's a recipe for a localized medical crisis. In a high-stress moment, you don't need a vocabulary lesson.
No, you really don't.
You need a cognitive map. So today we are investigating the architecture of how we actually build that map.
Which is such a critical topic right now.
It really is. We want to welcome you to our deep dive into how everyday people consume, process, and actually interact with high-stakes medical information.
Yeah, it's a fascinating area to explore.
And we are doing this by examining a very specific framework from today's source stack. It's called Gallbladder Inflammation, the iMedix Guide to Cholecystitis.
It's a great example to use.
Right, we are using this as a lens to dissect how patient education really must evolve. Because in a world overflowing with complex medical jargon, how do you, the everyday patient, find reliable health information?
Well, looking under the hood of iMedix provides a really fascinating case study for this.
They operate as an independent medical information platform, right?
They do, yeah. But the compelling narrative isn't simply the existence of their database. It's their very specific editorial methodology.
The way they actually build the content.
Exactly. When we analyze how they deconstruct the pathology of a condition like cholecystitis, we uncover a much larger story.
About medication safety.
Yes, and the democratization of medical knowledge, and really just how we frame clinical risk for the layman.
Okay, let's unpack this, because before we can evaluate their architectural solution, we really need to properly diagnose the crisis of medical misunderstanding that necessitates it in the first place.
That's a good place to start.
The source material highlights a really fundamental problem. Basically, there is a catastrophic gap between the clinical data generated by pharmaceutical trials and actual patient comprehension.
And the origin of that gap is structural. Clinical data is inherently stripped of human context by design.
Wait, by design, why?
Because when researchers publish a paper or file a drug application, they rely on a highly specific, standardized lexicon. It's meant to insulate the findings from emotional bias.
Oh, I see. So it's supposed to be cold and factual.
Precisely. They deal in hazard ratios, Kaplan-Meier survival curves, statistical probabilities of adverse events.
Which means absolutely nothing to the average person.
Right. That language is a mathematical tool for regulators. But a patient sitting at home at 2 in the morning with severe abdominal pain isn't processing statistical probability.
No, they are panicking.
Exactly. They are operating in pure survival mode. They're just trying to extract a binary, am I in danger, from a document written in fractional risks.
And human psychology fundamentally breaks down when asked to process fractional risk during acute stress. We just don't synthesize those numbers logically.
We really don't. We tend to pendulum swing.
Right. We either latch onto the rarest, most terrifying side effect listed like, Stevens-Johnson syndrome and spiral into totally unnecessary panic.
Which happens a lot.
Or we experience the cognitive overload of reading a 1,000-word monograph and just tune the entire thing out.
Falling into a dangerous complacency, yeah.
Exactly. We just ignore the actual high-probability warning signs.
And the downstream effects of that pendulum swing are massive, particularly when we look at medication noncompliance.
People just stop taking their meds.
Yeah, the statistical realities of adherence show that a staggering percentage of patients abandon newly prescribed life-saving therapies within the first 30 days.
That is wild.
It is. And often, this isn't because the drug actually failed them. It's because the patient encountered a poorly contextualized list of side effects, grew terrified of like a 0.1% risk of liver toxicity, and just stopped taking the medication.
Without even consulting their doctor.
Exactly. We see these cascading health failures stemming purely from data illiteracy.
You know, the danger of that data illiteracy is exactly why I look at standard medical warnings, like that folded paper stapled to your pharmacy bag, and I see the exact same user experience failure as the terms and conditions on a software update.
Oh, that is a perfect analogy.
Yeah, right. Everyone knows you are legally supposed to read the terms and conditions before clicking accept. But the text is 50 pages long.
And written in dense legalese.
Exactly. It's designed to indemnify the corporation, not to educate the user. So what do? We furiously scroll to the bottom and hit agree just to use the software.
We all do it.
We do the exact same thing with standard medical warnings. The sheer density of the indemnification language trains the patient to ignore the text entirely.
But the stakes are so much higher.
Yeah, because ignoring software bugs means your app crashes. Ignoring a black box warning means you might suffer acute organ failure.
If we connect this to the bigger picture, that phenomenon of defensive scrolling is exactly where independent editorial platforms have to intervene.
Right, they have to step into that gap.
The role of a medical research team isn't to just hand you the terms and conditions of your physiology. Their mandate is to act as a highly specialized translator.
Taking the complex stuff and making it usable.
Precisely. Extracting the clinical clauses that actually impact your morbidity and mortality and restructuring them into an intuitive framework.
Which brings us to the economics of that translation. The sources emphasize that iMedix operates with an independent editorial and medical research team.
Yes, independent being the key word there.
But I mean, independent is a heavily co-opted buzzword online these days. Every wellness blog claims independence. What are the actual structural safeguards that differentiate a platform like this?
True independence in the medical data industry requires a radical divorce from commercial funding mechanisms.
So no pharmaceutical money.
Exactly. Most freely available medical literature online is subtly, or sometimes overtly, subsidized by pharmaceutical manufacturers or medical device companies.
Or large hospital networks doing SEO marketing, right?
Oh, yeah, absolutely. And this creates an insidious environment of so-called sponsored content disease awareness campaigns.
It's basically native advertising for drugs.
It is. If a platform relies on pharma ad tech, their editorial firewall is completely compromised.
So the independent part really matters for safety.
It does. An independent entity strips away that commercial bias. It ensures the information hierarchy, like what gets placed at the top of the page versus what gets buried in a footnote, is dictated strictly by patient safety.
Not reputation management for a drug manufacturer.
Exactly. The focus remains squarely on patient education rather than product promotion.
I look at these independent databases, though, and honestly, the sheer volume of data still seems totally overwhelming.
It can be a lot to take in.
I mean, it's great to have an interactive database, but how does an editorial team prevent an educational resource from just becoming another dry, generic drug monograph that nobody wants to read?
That is the real challenge.
Because putting the onus of medical detective on a patient who is actively in a pain crisis seems like a massive cognitive ask.
Yeah, if the user interface requires a medical degree to navigate, it fundamentally fails. The cognitive burden is exactly why the architecture must prioritize mechanistic understanding over just encyclopedic listing.
What do you mean by mechanistic understanding?
Well, if a database just lists nausea, fever, and abdominal pain, it leaves the user to connect all the dots.
Which they can't do if they aren't doctors.
Right. A sophisticated educational resource mitigates that cognitive load by explaining the why. It strings the symptoms together into a logical, physiological narrative.
So it tells a story about what the body is doing.
Exactly. To evaluate how effectively this is done, we should really examine the anatomy of the specific guide highlighted in our sources, the breakdown of cholecystitis.
Okay, let's get into the cellular weeds of the medical reasoning then. The guide focuses heavily on explaining who is affected, what cholecystitis actually is, and the underlying mechanisms.
Right. It doesn't just list the problem.
Right. So to avoid turning this into a broad gastrointestinal survey, let's zero in entirely on the biliary system. What is the actual physiological cascade happening when a patient develops gallbladder inflammation?
Well, the pathology really begins with the physical properties of bile.
Okay, set the scene for us.
The gallbladder is a small sac situated beneath the liver, and it essentially acts as a reservoir. The liver produces bile, which is a complex fluid made of water, bile salts, bilirubin, and cholesterol.
What does bile actually do?
It is essential for emulsifying dietary fats. So when you consume a lipid-heavy meal, say a big cheeseburger, the digestive tract releases a hormone called cholecystokinin.
Cholecystokinin, got it.
This hormone signals the gallbladder to contract. It squeezes concentrated bile through a narrow passage called the cystic duct, down the common bile duct, and into the small intestine.
Okay, so that is the optimal mechanical flow. The plumbing is working as intended. But the source text deeply explores the role of gallstones disrupting this flow.
Yes, that's where things go wrong.
How do those stones formulate in the first place?
The formation of gallstones, which is clinically called cholecystitis, is fundamentally a problem of supersaturation.
Meaning there's too much of something in the fluid.
Exactly. If the liver secretes bile that contains a high concentration of cholesterol-like, more than the bile salts can successfully dissolve, the excess cholesterol precipitates out of the solution.
It just kind of falls out of the liquid state.
Right. It crystallizes, eventually nucleating into solid stones. Now, an individual can harbor these stones for decades.
Wait, really? Decades?
Oh, absolutely. They can just sit quietly in the dependent portion of the gallbladder, entirely asymptomatic. People walk around with them every day and have no idea.
But cholecystitis isn't just the mere presence of stones. The critical failure happens when the plumbing is physically compromised, right?
Exactly. The transition from asymptomatic gallstones to an actual clinical event occurs when one of these stones is swept up in the turbulent flow of bile.
During one of those contractions you mentioned.
Yes, during a gallbladder contraction, a stone gets pushed up and becomes impacted in the cystic duct. This creates an absolute mechanical obstruction.
So the pipe is totally blocked.
Blocked solid. But the hormonal signals from the gut are still demanding bile because of that heavy meal. So the gallbladder continues to spasm violently against a closed system.
Oh, wow. The resulting pressure must be immense.
The intraluminal pressure rises exponentially. This initial phase, which is characterized by really intense episodic pressure, is referred to as biliary colic.
Okay, biliary colic. So that's just the pressure part.
Right. And if the stone eventually dislodges and falls back into the body of the gallbladder, the pressure drops and the attack resolves.
Well, what if it doesn't drop back down?
That's the danger zone. Acute cholecystitis develops when that stone remains stubbornly wedged in the duct. The sustained obstruction initiates a devastating inflammatory cascade.
So we move from a mechanical plumbing issue to a vascular and cellular crisis.
Exactly.
How does the organ essentially begin to destroy itself?
As the trapped bile accumulates, the gallbladder distends. It swells up. The physical swelling stretches the walls of the organ so tightly that the internal pressure eventually exceeds the venous blood pressure supplying the tissue.
Meaning the blood can't even get into the organ anymore.
Precisely. It halts capillary blood flow, leading to localized ischemia, which is tissue death due to a lack of oxygen.
That sounds incredibly painful.
It is. And simultaneously, the stagnant bile salts, particularly one called lysolecithin, act as severe chemical irritants. They directly damage the mucosal lining of the gallbladder wall.
And wherever you have stagnant fluid and ischemic tissue in the human body, you have an open invitation for bacterial colonization.
You're jumping right to the most perilous stage, but yes, that is the final stage of the pathogenesis infection risk.
Because the gut is already teeming with bacteria.
Right, the gut is full of flora. In the setting of an obstructed ischemic gallbladder, gram-negative bacteria like Escherichia coli or Klebsiella can easily translocate into that stagnant bile pool.
So the fluid itself becomes infected.
Yes. What originated as a microscopic cholesterol crystal has now triggered mechanical obstruction, ischemic necrosis, chemical inflammation, and bacterial proliferation.
See, providing a patient with that level of mechanistic reasoning changes everything.
It completely reframes their understanding.
Because merely stating cholecystitis is a severe inflammation just fails to capture the urgency. But walking someone through the physics of the block duct and the subsequent tissue ischemia makes perfect sense.
It intellectually arms the patient.
Let's map this underlying pathology to the physical symptoms then, because distinguishing these signs from generic gastrointestinal distress is super crucial.
Very crucial. The hallmark clinical manifestation is severe, unrelenting pain in the right upper quadrant of the abdomen.
So it's very specific to that spot.
Yes. Due to the intense inflammatory response, this is not a vague, diffuse discomfort. It is localized and highly sensitive to palpation.
Now, the guide also points out that patients frequently report pain radiating up into their right shoulder blade.
The referred pain, yes.
Assuming our audience is familiar with the basic concept of referred pain, let's go a layer deeper. Why the shoulder, the gallbladder, and the shoulder blade are anatomically completely distinct.
It comes down to our embryological wiring.
How we develop in the womb.
Exactly. The diaphragm, which sits just above the liver and gallbladder, shares a neurodevelopmental origin with the structures of the neck and shoulder. They're both innervated by the phrenic nerve.
Okay, the phrenic nerve connects them.
Right. When the massively inflamed gallbladder physically rubs against the underside of the diaphragm, it irritates those phrenic nerve endings.
Oh, I see where this is going.
The brain interprets signals along that shared neural pathway, and it mistakenly projects the sensation of pain onto the right cutaneous shoulder dermatome.
That is fascinating. The brain just gets confused by the wiring.
It does. And alongside this, the systemic inflammatory response and the developing bacterial infection trigger severe nausea, vomiting, and a notable fever.
Here's where it gets really interesting, because understanding those systemic signs is how we act as medical detectives.
And that's what a good guide empowers you to do.
Right. The guide places a heavy emphasis on mitigating real-world patient misunderstandings. The instinct for a patient who just ate a heavy meal and feels intense upper abdominal pain is to self-diagnose it as severe indigestion or perhaps a touch of food poisoning.
It's a very common and dangerous mistake.
So how does an effective educational platform forcefully differentiate an urgent case of cholecystitis from a benign gastric issue?
The differentiation really hinges on analyzing duration, progression, and the presence of systemic markers.
Okay, break that down for us. Duration first.
Indigestion, or even the temporary pain of biliary colic we talked about, has a self-limiting trajectory. Generic dyspepsia generally responds to antacids, posture changes, or just time.
It eventually goes away.
Right. Biliary colic typically peaks and then steadily resolves within a few hours as the gallbladder muscle eventually fatigues and relaxes.
But cholecystitis doesn't.
Acute cholecystitis does not yield. Because the stone remains impacted and the ischemic cascade is fully underway, the pain persists well beyond the 6-hour mark, and it often escalates in severity.
So duration is the first major red flag. If it lasts past 6 hours, you need to worry.
Yes. Duration, coupled with the systemic immune response.
Because indigestion doesn't cause a fever.
Exactly. Simple indigestion does not induce a fever. It does not cause a sudden spike in white blood cells or C-reactive protein levels.
So the body is sounding the alarm.
It is. When a patient notes that the severe pain is now accompanied by chills, a high temperature, and an inability to even take a deep breath without agonizing discomfort, they need to know that's a red line.
The educational guide must clearly signal that they have crossed the threshold from a gastric nuisance to a systemic medical emergency.
Yes, one requiring immediate diagnostic imaging.
And when they finally arrive at the emergency department, how do we demystify that diagnostic process? Because you mentioned earlier that the standard X-ray is pretty much useless here.
It is largely useless because the vast majority of gallstones are composed of cholesterol, which is radiolucent.
Meaning the X-ray beams just pass right through them.
Exactly. They leave absolutely no shadow on the film. Therefore, the gold standard frontline diagnostic tool is the abdominal ultrasound.
Oh, like they use for pregnancies.
Very similar, yes. It utilizes high-frequency sound waves to map the density of the tissues inside the abdomen.
What specific sonographic evidence is the radiologist hunting for? Because they aren't just looking for the presence of stones. As we established, silent stones are super common.
Right. Finding a stone doesn't prove it's an emergency. They need proof of the actual inflammation.
Exactly. So what does inflammation look like on an ultrasound?
They are evaluating the downstream effects of the pathology we just discussed. They measure the thickness of the gallbladder wall.
How thick is too thick?
Anything over 3 millimeters is highly suspicious for acute edema and inflammation. They also look for pericholecystic fluid.
Which is what, exactly?
It's fluid that is physically leaked out of the engorged organ into the surrounding abdominal space. And crucially, they will test for a sonographic Murphy sign.
Let's detail the mechanics of the Murphy sign, because it perfectly illustrates the intersection of anatomy and pathology. How do they perform it?
During the ultrasound, the technician presses the transducer probe firmly against the right upper quadrant, just under the rib cage.
Right where the gallbladder is hiding?
Exactly. They then instruct the patient to take a deep inhalation. As the lungs expand, the diaphragm is forced downward.
Which pushes everything below it down, too.
Yes, it pushes the liver and the inflamed gallbladder directly into the path of the stationary probe.
Oh, that sounds like a terrible idea for the patient.
It's very jarring. When that exquisitely tender ischemic gallbladder makes contact with the pressure of the probe, it triggers a sharp, reflex-level surge of pain.
So the patient reacts physically.
Yes, it causes the patient to abruptly stop breathing mid-inhalation. That involuntary respiratory arrest is a positive Murphy sign.
And that pretty much seals the deal for the diagnosis.
It heavily corroborates the diagnosis of acute cholecystitis, yes.
But what if the ultrasound results are sort of equivocal? Say the wall thickening is borderline. How do they definitively prove the cystic duct is obstructed?
That requires a functional study, typically a hepatobiliary immunodiacetic acid scan, or a HID scan for short.
HID scan, how does that work?
The patient is injected with a radioactive tracer isotope. This tracer is specifically synthesized to mimic bilirubin.
So the body treats it like normal bile material.
Exactly. It gets pulled from the bloodstream by the liver and secreted into the bile. A gamma camera then tracks the flow of this glowing tracer in real time.
So they can literally watch the plumbing work.
They can. If the tracer flows seamlessly from the liver, down the common bile duct and into the intestine, but completely fails to enter and illuminate the gallbladder.
Then you know the door is locked.
Exactly. It provides unequivocal physiological proof that the cystic duct is physically blocked.
This raises an important question. Understanding the diagnostic mechanics gives the patient a lot of clarity, but navigating the subsequent treatment protocols introduces a whole new labyrinth of risk.
It certainly does. The intervention phase is complex.
The final section of our source material stresses the importance of what they call contextualizing care, specifically analyzing regulatory warnings and comparative drug data.
Right, because the treatment for acute cholecystitis is multi-pronged. It involves immediate fasting to halt the release of cholecystokinin.
So no more food to trigger the spasms.
Exactly. Plus, aggressive intravenous hydration, potent analgesia to manage the severe pain, and broad-spectrum antibiotics to neutralize the translocated gut bacteria.
And ultimately surgery, right?
Yes, the definitive curative treatment is almost universally a cholecystectomy, the surgical removal of the diseased organ. But the interim medical management is fraught with nuanced pharmacological decisions that a patient really must understand.
I can hear a skeptic out there asking, why? If I'm lying in a hospital bed with an infected organ, why do I need to care about the regulatory history of the pain medication? Why not just blindly trust the attending physician to dispense the correct compound?
Because, blind trust just removes the patient from the safety equation entirely. And, no clinician is infallible.
They're human, they make mistakes.
They do. Providing regulatory and comparative context empowers the patient to monitor their own adverse reactions. Let's examine the pain management strategy as an example.
Okay, biliary pain is excruciating.
It's one of the worst pains you can experience. Historically, the reflex in the ER was to administer potent opioids like morphine.
Which makes sense for severe pain.
It does, but however, opioids carry massive regulatory context black box warnings for respiratory depression, profound dependency risks, and complex metabolic interactions.
But beyond the addiction risk, isn't there a specific mechanical issue with opioids and the biliary tract?
There is. There's a long-standing, heavily debated physiological concern that opioids, specifically morphine, can actually induce spasms in the sphincter of Oddi.
The sphincter of Oddi, what is that?
It is the muscular valve that controls the flow of bile into the small intestine.
So if you administer a drug that causes that valve to clamp shut,
you theoretically increase the biliary pressure behind it, potentially exacerbating the underlying pain and mechanical stress of the cholecystitis.
That sounds completely counterproductive.
It can be. So an independent platform like iMedix would highlight this comparative data. They would explain why a physician might deliberately bypass an opioid and instead order a high-dose intravenous NSAID like ketorolac or Toradol.
Oh, Toradol, right. That's a strong anti-inflammatory.
Exactly. The database contextualizes that choice. An NSAID inhibits the synthesis of prostaglandins, which directly addresses the localized inflammation in the gallbladder wall.
Without messing with the valve.
Right, without carrying the systemic baggage of respiratory depression, without the risk of physical dependency, and without risking a spasm at the sphincter of Oddi.
It's literally the difference between providing a topographical map versus just giving someone a set of GPS coordinates.
That's a great way to put it.
If a platform simply lists Toradol as a treatment, that's just a coordinate. It tells you where you are standing.
But nothing about the landscape around you.
Exactly.
Yeah.
But if it maps out the steep cliff of opioid addiction on one side and the risk of sphincter spasms on the other, It contextualizes exactly why the physician chose the NSAI path.
It transforms the patient's experience.
Right, from why won't the doctor give me the strong stuff into an informed realization of, oh, the doctor is actively protecting my biliary mechanics.
And that topographical mapping applies equally to the antibiotic regimens. To combat those gram-negative bacteria we mentioned, physicians frequently employ fluoroquinolones.
Those are pretty heavy-duty antibiotics, right?
They are highly effective, broad-spectrum antibiotics. However, they carry intense FDA black box warnings for severe, sometimes irreversible side effects,
Like what?
like the upregulation of specific enzymes that can actually degrade collagen. This can lead to sudden tendon ruptures, particularly the Achilles tendon.
Oh my God, the Achilles tendon, just from taking an antibiotic.
Yes. And if the patient is ignorant of that regulatory context, they might experience profound heel pain a week after discharge and assume it's just general post-hospital fatigue.
They would completely miss the fact that they are suffering a severe adverse pharmacological event.
Precisely. Now, in the context of a life-threatening systemic infection, the clinical benefit of eradicating the bacteria far outweighs the statistical risk of a tendon rupture.
So the prescription is still justified.
The prescription is totally justified. But the patient absolutely must be educated on the pharmacology so they can serve as an active surveillance system for those rare adverse effects.
Because the doctor isn't going to be at home with them a week later.
Exactly. True medical literacy isn't about second-guessing the physician. It's about sharing the burden of vigilance.
So what does this all mean for you, the listener? When we zoom out and synthesize this entire breakdown, we see a profound paradigm shift in how healthcare data must be structured.
It really is a shift in the entire foundation of patient care.
We've transitioned from discussing the macroeconomics of pharmaceutical marketing all the way down to the micro-pressure of a single impacted gallstone, and the through line is absolute.
Abstract medical data, stripped of its mechanistic context, is a massive liability to the patient.
The liability lies in the cognitive friction. We have diagnosed why standard medical warnings fail. They just mimic the defensive legal architecture of software terms and conditions.
Which nobody reads.
Exactly. We have seen why true editorial independence is necessary to strip away commercial biases and elevate clinical realities.
It's the only way to ensure safety is the priority.
And by dissecting the pathogenesis of cholecystitis, we proved that when you explain the underlying physics and biology of a disease, the supersaturation of cholesterol, the ischemic tissue necrosis, the referred neurological pain loops, you eliminate the panic of the unknown.
It reorients the entire relationship between the individual and their own physiology.
So the next time you find yourself scrolling through a symptom checker at 2 in the morning or holding a prescription bottle wrapped in a novel of side effects, I want you to reject the baseline summary.
Don't just accept the raw data.
Exactly. Do not settle for the raw, decontextualized coordinates. Demand the topographical map. Look for the independent resources that explain the cellular why and the pharmacological how.
And, I want to leave you with a final thought regarding the ultimate trajectory of this data evolution.
What's the end game here?
Well, as independent databases continue to refine their user experience, rendering these highly complex pharmacological and pathophysiological concepts fully accessible to the layman, we are witnessing a tectonic shift in clinical power dynamics.
It's really the end of the paternalistic era of medicine.
Precisely. The traditional unilateral model, where the physician dictates therapy from a position of exclusive knowledge and the patient just passively complies, is becoming obsolete.
It's outdated.
It is. The question we must ask ourselves is, how will clinical practice adapt when the patient arrives in the examination room, not as a frightened, uneducated variable, but as a fully informed mechanistic co-pilot in the navigation of their own survival?
Let's hope the medical establishment is ready to share the wheel. Because when the diagnostic waters are murky, we need every piece of context we can get. Until next time, keep diving deep.